So I'm delighted to be here talking to you about a sequenced treatment for anorexia nervosa that we are just delighted to talk to you about a sequenced treatment for anorexia nervosa using a ketogenic diet, a therapeutic ketogenic diet, and ketamine. You are the first to hear about this work. It is in press as we speak. I have no disclosures, but one disclaimer, and that is that it's not ready for prime time yet. This is not a presentation that should allow you to go home and offer this directly to your patients. But given that, let's begin. Helen of Troy was and had a face that was so beautiful that she launched 1,000 ships. Caroline of New York has a story that was so compelling that it has launched more than 10,000 reads, and her story has been read by more than 90% of all articles published in Frontiers in Psychiatry. Yes, this talk is the story of a pilot study that we launched based on this case report. And it was launched from a tiny little place in the middle of nowhere, Connecticut, called South Windsor, at a practice that is a private psychiatry clinic with a group of extraordinary women. Barbara Skolnick is an internist who stopped at nothing to help her niece recover anorexia. Beth Supik-Kania is an internationally renowned ketogenic dietitian who has set the standard for ketogenic therapies in epilepsy and other neurologic disorders. And Caroline Beckwith is a research assistant, clinical peer counselor, expert in the lived experience of anorexia and in its sustained remission and recovery. And what I want to present to you is a translational symphony that came together in a human clinical trial that is based on science that goes back at least 100 years. Our conclusion and our takeaway I'll give to you at the very beginning, and that is that a therapeutic ketogenic diet followed by ketamine infusions is promising in anorexia. I would say, thank goodness, because anorexia is a deadly disease. It has the highest case mortality rate of any psychiatric disorder. It is 6 times more deadly than all human cause mortality across adults. 10% of people with anorexia die within 10 years of contracting it. 18 to 20% die within 20 years. There is a death every 52 minutes, and 20% of people with anorexia kill themselves. So given that, what are the options that we have now for treating them? I'd say, although we have many options, and the options have been present for quite a long time in stepped care and with integrated teams, they're unsatisfactory, and there's no known pharmacologic agent that's useful in anorexia. Although we have a number of treatments, up to 35% of people with anorexia suffer a prolonged course. Refeeding is often ineffective, and patients become chronically ill. And when they do, they're trapped and we're trapped as their clinicians. But what happens when the N of one that's trapped is somebody that you actually care about and love? For Barbara Skolnick, my collaborator, that was her niece. And when it's really somebody that you care about, you do anything to try to find something for them. That's how our story begins, and that's how this story begins. I'm going to tell you 2 stories today: the story of the science underlying our hypothesis and the story of our study and our study results. This is a brief overview of the science that we'll touch on, and we'll start with the adapted to flee famine hypothesis. This is a hypothesis put forward in 1972 that is both revolutionary and evolutionary. It is based on the idea that for migratory people, some of the core features of anorexia, food restriction, hyperactivity, the ability to run, and the ability to deny starvation, was actually potentially evolutionarily advantageous and may have facilitated migration. Fast forward to the 1950s. Anorexia has both a biologic and a metabolic basis. In 1952, the first animal model for anorexia was developed when the researchers, Hall and his colleague Hanford, got a little bit of extra money for their lab and put some cages in some running wheels in their rodent cages. And when they did, and they restricted the time of feeding slightly or the amount of feed slightly, what they found was that some young adolescent female animals ran instead of ate, and ran instead of ate, and ran instead of ate, and ate less and died of starvation unless they were rescued from the paradigm. This animal model of anorexia is an extraordinarily outstanding animal model and has been used ever since, and supported and replicated many times. 20 years later, the first intervention was brought into the animal model using a dietary intervention when it was found that a high-fat, low-carb diet reversed anorexia in these animals, rescued them from the paradigm, and prevented death. You see where I'm going? This has been well replicated. Chia Aoki brought this fast forward. Chia is the world's leading expert in using the ABA model in anorexia. She has a lovely poster in this symposium, which you should take a look at. She was the first scientist in the world to study ketamine in the ABA model. She gave her animals 1 intraperitoneal injection of ketamine, young adolescent females in the ABA paradigm, running like crazy, losing weight like crazy. And she found that it did the same thing. It increased their eating. It immediately decreased their running, and it decreased anxiety-related behaviors associated with marble burying. So ketogenic diet, high fat, low carb, ketamine. Could we find a way to maybe work this into clinical practice? Well, Barbara put together the science, reached out to Beth, the ketogenic dietitian, reached out to Chia, who had done the ketamine work, and together we came up with a treatment for one singular person that put that one singular person into remission for not just 6 months, but now for 2.5 years. And so we kind of thought maybe we're onto something. Maybe this could be a new paradigm. Maybe we could find a way to address the metabolic dysfunction in this really deadly disease, to turn down the anorexic voice, to reclaim free headspace, and to potentially achieve remission and recovery in so many patient-reported important outcomes. So let's start with the ketogenic diet. It's an old idea. It goes back 100 years, when Wilder in 1921 found that kids with epilepsy stopped seizing when they went on extended religious fasts with their family. But you can't starve kids. So he came up with the idea of replacing starvation ketosis with nutritional ketosis. Now, nutritional ketosis is a natural metabolic state that occurs when we shuttle energy factors from within the mitochondria from glucose to ketones. The brain can only use these 2 sources for energy. When you shuttle the ketones, you need a serum ketone level of 0.1 millimoles per liter. And you can do that nutritionally without starvation. Now, no one understands really how the ketogenic diet works, not in epilepsy, not in other neurologic conditions, certainly not in psychiatry, but there are many, many potential benefits, as we've heard about in this conference, to the idea of reducing inflammation, and ketosis and ketones potentially have that as a putative mechanism of action. Whoops, I'm sorry, way back. Let's go back to that slide. And to go back one more. There we go. So I want to move to talking about the clinical work looking at ketamine in anorexia, and then we'll put these 2 together. First, let's take a look at the world literature. It starts right here in the UK. It started in 1998. Mills wrote a paper taking a look at 15 anorexics that he treated with ketamine. They were a poorly described group, but each one received 180 milligrams of ketamine, 180 milligrams over 9 hours. The difficulty was they had multiple comorbid states. Some got 2 infusions, some got 9 infusions. The interval between infusions varied. But what he reported was that 9 out of his 15 patients went into remission from some of their compulsive behaviors associated with anorexia. And that report lay fallow for 20 years. No one did anything with it. We published our little case report. And then shortly after that, there was another case report published and another case series. There are a total of 21 patients described in the world literature with anorexia that have been treated with ketamine. And not all of them have anorexia, because in that last little case series, there was a mix of eating disorders, and the range of doses used in these studies varies. And in the last little case series, there was both IV and IM ketamine used. Let me go through it again. 180 milligrams in mils. In our case report, titrated doses, 0.75, 1, 1.1, 1.2, remission after 1.1 after the 3rd ketamine infusion over 45 minutes. One case report in Deschamps, static dose, repeat dose, several infusions, and then a mix of IV, IM. Our index case was the one that had achieved sustained remission of over 6 months. And as I mentioned, now going into 2.5 years. What was striking was that in the case report, there was a quote that is a little hard to believe. And here's the quote. The quotes, I know this sounds ridiculous, but I'm no longer anorexic. little unbelievable, right? Do anorexics really say that? We wanted to see if we could play it again. So our question was, is this really reproducible? And so that's what we set out to do. We did a little study, a little pilot trial that I'm going to tell you about, with the hope that today we might be able to stimulate research and stimulate collaboration and plan larger studies and get you interested. It's one of the reasons I'm so excited to be able to present this to you. So for our pilot study, we asked two questions, two important questions. Is this unique treatment, this sequence treatment of keto first followed by ketamine, is it safe enough to do on an outpatient basis in other people with anorexia? And was the response of our index patient actually reproducible, or was it a one-off? Well, as you know, designing studies are not for the faint of heart, and designing little studies when you're a clinician and not a researcher are not for the faint of heart. We faced limited funding. We're not academicians. The prevailing mindset was against us. The eating disorder community roughly thought we were a little nuts in considering a ketogenic diet and anorexia. And so we had this impossible little question of, how do we set up a small study? How do you set up a clinical trial that's open-ended, that's flexible enough, with a flexible design, maybe with flexible dosing, with ketogenic diet foods that would vary from participant to participant based on their tastes? Could we do it safely? Could we do it quickly? Could we do it in a pandemic, for Pete's sake? And could we test two unpaired treatments that had never really been tested together? And would actually anybody approve this? So we just decided to jump in. This is a family trait. My daughter jumping off a cliff in southern Italy, she takes after her mother. And so what we did was got a sponsor. Homeostasis Therapeutics sponsored us. Advera approved our protocol, and this was registered in clinicaltrials.gov, and we began recruitment looking at adults with severe anorexia for at least 3 years, severe and chronic anorexia, who were treatment resistant, who had failed at least 2 adequate treatments, who were not too cachectic. We wanted a body mass index of 18.2 for safety reasons, because we were jumping into untested waters. A stable weight for the past 3 months, no substance abuse, no psychosis, no suicidal ideation. And we excluded adults with significant concurrent diseases that would put them at risk when they entered ketosis, including inborn errors of metabolism and metabolic dysfunction that would preclude them from being able to use ketones as an energy source in the brain and in the body. Right, we excluded bulimia, pregnancy, QTC prolongation, unmanaged hypertension, psychosis, and again, active suicidal ideation and prolonged QTC. Again, we wanted to be safe. Here's how we screen them. In terms of eligibility, the screening process was a tripartite process: an online screening form, an extensive phone interview, and ultimately an investigator interview by video, so that I could reaffirm their psychiatric diagnosis using DSM-5 and their eating disorder diagnosis using the EDA-5. We obtained all of this, including critically a serum acyl carnitine level to exclude those metabolic disorders. And in fact, in our study, that's what we ended up doing. The study took place across 3 different sites. So in addition to screening them, we had to see if they were willing to do studies across these 3 sites. The first was an immersive experience in an inn-like venue, living with us for 2 days while we monitored them closely. The internist there is, the dietitian is there, the food is there. We're cooking with them, we're teaching them what to make, and we're eating with them, and everybody gets into ketosis all together in 48 hours safely and without side effects, potentially without side effects. Secondly, at home, the continued adoption and adaptation to ketosis over a minimum of 4 weeks. We'll talk more about that. Then come into the clinic up to 6 times for 90-minute appointments for a 45-minute infusion that starts at 0.75 and potentially goes up and or down from there. We'll talk about that. And then stay in the study for 12 months. We used qualitative and quantitative outcome measures. And what we did was first assess breath acetone measures as a measure of ketosis. It's not ideal because it's not a serum beta hydroxybutyrate measure, but it is approximate, easy, and inexpensive to do. We followed body weight very carefully. We didn't want our anorexics to lose weight on a ketogenic diet. They loved the idea of keto, right? We wanted to see if we could create nutritional ketosis without weight loss. We used eating disorder scales looking at response and remission. The 2 top ones, look at those. The middle one, the EDE, looks at severity of eating disorder symptoms as a measure throughout the study and throughout the follow-up. And we followed changes in food preferences for fats. That's the FPQ at the bottom. In addition, we looked at the PHQ-9 at the beginning and throughout the study. And we did extensive interviews, food recall diaries, and written reflections throughout to obtain some qualitative data about what their life experience was like as they went through this. Let's look at who we studied. 5 women, all women, from 29 to 45, all white, all college educated, many with advanced degrees, most employed, 2 single, 3 married, 2 with children, and really sick. Take a look at this. Every single one of them, 29 to 45, had developed their eating disorder as an adolescent. Every single one of them had had multiple partial hospital programs. Most of them had been hospitalized recurrently. They all had food rituals. They all had body dissatisfaction. Most of them had exercise compulsions. And on top of that, most of them had a remote history of binge purge without true bulimia. And they were all on all different kinds of medicines managed by their prescribers. The one with lamotrigine tapered it before the study started. Everyone else was free to continue treatment as usual with their providers. And they were all psychiatrically comorbid with other disorders. Every single one met clinical criteria for major depression at the beginning of the study, and all of them had a smattering of other anxiety disorders. One had remote substance abuse. On top of that, medical comorbidity was broad and involved both eating disorder and non-eating disorder. Problems, migraine, GERD, PLMDD, tinnitus, chronic pain, bilateral hearing loss. We keep going, iron deficiency anemia, asthma, irritable bowel, hyperlipidemia, diarrhea. 2 had had life-threatening complications of their eating disorder already before they came to us. 1 had had a respiratory collapse and respiratory arrest as a direct result of her anorexia. Another one had had 4 different episodes of C. diff following refeeding attempts with TPM. When I say they were ill, I mean they were really ill. Could our protocol work for them? Here is what the protocol looks like briefly. It was the screening, the 2-day immersion into ketosis, the take home for at-home period with therapeutic ketogenic diet. That's what TKD means, for 4 weeks. Hang on to that. And then there was a decision point. If you're in ketosis, you've maintained nutritional ketosis, you're doing well, you can move on to ketamine. Or you can decide, patient can decide, if they wanted to continue the TKD for an additional 4 weeks. If you are not in nutritional ketosis, you get one more chance, another 4 weeks to get into nutritional ketosis, to get with it, to maintain it, and then you get to go to ketamine. Our group split. Some did ketosis for 4 weeks, some did ketosis for 8, all went on to ketamine, all are in follow-up. Here's what the diagram looks like. Vertically, we screened 25 people, we eliminated 20, 5 were in our ultimate group. 3 of them maintained nutritional ketosis for 4 weeks, went on to ketamine, and importantly here, that little group who did 4 weeks dropped the ketogenic diet. They liberalized it after their ketamine infusions ended. The ones who selected to stay on it for an additional 8 weeks had ketamine treatment and elected to stay on a therapeutic ketogenic diet into the follow-up period. And I'm going to present you 6 months of follow-up. And the contrast between those 2 groups is pretty striking. The therapeutic ketogenic diet that Beth designed for them is quite different from the average American diet. We proposed a diet where the macronutrient ratio was 70% fat, 20% protein, 10% carbs. Comparatively, the standard American diet is 35% fat, 20% protein, 50% carbs. We encouraged 3 meals and 2 snacks a day. We encouraged patients to rely on hunger and satiety rather than on portion control. Ketogenic food, as you can imagine, and this kind of diet is nutritionally dense. It's very appealing to eat only a little when you are used to eating only a little. So our participants really did this. They actually ate. In fact, they talked to each other throughout that whole immersion program saying, can you believe we're eating? We never did this in treatment. So there was a very high acceptance of this. Here is that one measure that we're monitoring, breath acetone level, and we used a commercial monitor, as you can see here. We wanted to look for on our monitoring app, which could be streamed and sent to us. We wanted to look for a number of 4 or greater to indicate some relative amount of nutritional ketosis. This is 66666 and forgetting to blow when it drops to 1, and 66666. This was something that we followed many times a day throughout the first several weeks, throughout the ketamine infusions, and even into maintenance. So let's talk about ketamine, right? That's what you're interested in. So our index patient started at 0.75 milligrams per kilogram. That's how we designed this to start, at 0.75, with the opportunity to go up from there. I can talk more about why that happened. The goal was to see if we could do the same thing, if we could just create a little bit of miracle after 3 infusions. What really happened is that every single person in the study had 6 infusions. They wanted the full thing. If 6 were available, they all wanted 6. We said, okay, we're going to give you 6. This is how the 6 went. Not as we had predicted, with a beautiful scale of 0.75 and then 1 and then 1.1 and 1.2. Some started to go up. 1 went way high because we had framed dissociation as desirable and potentially meaningful for them. 1 went higher. We'll talk about her later. Others went up and then actually wanted to pull back down a little bit, and the flexible dosing in the protocol allowed that. But if I take a look and show you participant by participant, on average, the dose of ketamine used here was about 1.0 milligrams per kilogram, again, with the one exception on the end. Let's take a look at the results. Here they are. In our women with chronic anorexia, there were no serious adverse events, either during the ketogenic diet or during the ketamine phase or in follow-up. Huge for us. Looking at treatment emergent adverse effects, nausea and migraine early, which resolved with hydration and migraine medicine in a migrainer, nausea and an infiltrate, and the usual blurred vision and minor EKG, heart rate and blood pressure changes that did not require clinical intervention or management during the infusions. Every patient dissociated. No patient was frightened by their dissociation. The interesting thing that caused some patients to request a lower dose and for me to actually pull back on their dose was that their dissociative experience got less clear and more perceptual and less useful to them. And we'll talk about what that means. One patient said that so much came to her that she was overwhelmed by it a few weeks later and had and needed some extra time to just process everything that she kind of learned about herself and her eating disorder. And one, at the 3-month point, had an intercurrent stressor that resulted in a flare of anorexia symptoms, weight loss, and entered residential treatment. So we're interested in recovery, right? We're interested in remission. The problem with recovery and remission is that the descriptions in anorexia are really all over the place. And with such a small study, and even though we had great study measures or good enough study measures, we really wanted to see if we could capture and take a look at whether or not our participants fell within normative ranges. Some of the studies, some of the scales that we used had actually normative ranges identified for participants and women at certain age strata. So we looked at, could our patients kind of get rid of their symptoms and look indistinguishable from norms? Here again are our primary and secondary outcomes. The CIA in terms of remission and recovery and the EDEQ do have normative data available for it. I'll skip this and move on to talking about the actual data. And I really want to show you the 2 groups. Here's our 8-weekers. 8-week CIA, this is response and remission. Does it improve? It looks like it's starting to come down, but look at what happens when they finish their ketamine infusions at K6 and they go into follow-up. All of the 2 people in this group achieved normative ranges. They remitted and got better and better and better as follow-up continued. One said, I think if I went to see a therapist now and they didn't know about me having an eating disorder, I wouldn't sound like I have one now. Take a look at the 4-weekers. They look good too, right? But let's look at what happens to them. They don't hit that normative range. Take a look at the EDEQ Global, the severity of eating disorders. Here we go by ketamine 6, by the 6th infusion. They're within the normative range. You cannot tell that their concerns about eating are any different from normative controls, and they get better and better and better over the 6-month follow-up period. Let's look at the shape concern. Their most aberrant score, again, gets better by the 6th infusion and continues to improve, indistinguishable from norms in our 8-weekers who continue the therapeutic ketogenic diet. Let's look at another measure of remission, acceptance of self on the EDREQ, the most difficult one by many experts to achieve. Here's what happens on this scale. Going higher means you're getting better. You're accepting yourself more. You're accepting your body more. You're accepting what you look like more. Here's what happens in 8 weeks. It starts, it takes off, and it keeps going and gets better. One said, I would say that some things are actually gone. I feel like it's possible, like this is how it is for some eating disorder people. In our 4-weekers, all over the place. In our dissociative qualitative stuff, this is just a smattering. My eating disorder is just tiny. It's a tiny red ant, and I just should stomp on it. And she felt like she did. Another said, I saw a lot of playfulness, thinking about myself in the future, not me as eating disordered anymore. That was incredibly meaningful for her. BMI changes were beautifully static, with the exception of one who had difficulty at 3 months, again, in response to that intercurrent stressor, and one who entered the study at an exaggerated BMI for her, who dropped to her usual anorexic BMI of 21, which is still not considered low by any means in anorexia. And we did not consider that to be an adverse event. Patients in general who stayed on the TKD found that they had a slightly higher preference for fats as they got used to eating more and more fats. And importantly for us here, the PHQ-9, I think this is significant, although I haven't done the statistics on it. In our group of 8-weekers, they came in less depressed than the others. This is a PHQ-9 where it's a PHQ-9 at every checkpoint. So this is, for example, one participant came in at 8, dropped, stayed low, slightly increased by week 6. Here's how high people came in that 4-week group. We think, but we don't know, that it may have been one of the things that pushed them to really want to get to the ketamine, because they really wanted relief of their depressive symptoms and hadn't gotten it as much in their diet. So what does remission really look like in our sample? Well, we're at the 9-month point. Everyone's still in the study, and we are still monitoring them and planning to monitor them all the way out to 6 months, all the way out to 12 months. We're excited by the data that we've seen so far. We're humbled by the limitations. You've seen them here. This was a small study. They were all Caucasian. They were 29 to 45. They were highly educated. They were highly motivated, and they continued care with their own team, right? We're aware that a therapeutic ketogenic diet has not been studied, that ketamine has not been studied in this escalating dose, that there isn't a published study starting at 0.75, that this hasn't been well worked out. And yet we put these two together and did it in a sequence, knowing that the infusion details were a little variable. We wanted people to stay in the study. And we wanted to see if the signal was a signal that was a qualitative signal or a quantitative signal that we would measure. There were so many unknowns, right? Our rating scales are imperfect. And yet we think we saw a little signal of positivity. And when we go back and think about, what do we really want to look at? What do we really want to talk about? Our first 2 big questions: did we see dramatic improvement in chronic anorexia in women with severe and enduring anorexia with our paired sequence of a therapeutic ketogenic diet followed by ketamine infusions? We think so. We think probably yes. In this group that did an 8-week TKD, 6 IV titrated infusions averaging about 1 mg per kg, who continued their therapeutic ketogenic diet afterwards, their anorexia symptoms stopped or got within normative controls by their 6th infusion. They got into remission within 3 months following the protocol, and they stayed in remission, and their remission got better. And their providers, some of whom have not been so friendly or supportive of this whole endeavor, confirmed that they were actually improved and in remission, that their symptoms were down, gone, that they had never seen them do so well. were there adverse events that interfered, that created a safety risk, or that put our patients at risk? No. And so I want to leave you with our take-home message as you leave Oxford later today, that we think a therapeutic ketogenic diet followed by ketamine infusions is promising for anorexia. And I invite you to jump in with us.
Super. Thanks very much, Laurie. Anyone got any questions? Got one here.
Yes, Alice from the Netherlands. Thank you for your very nice presentation. I have two questions, actually. The first question is if you've considered study only the diet and only the ketamine treatment, because now you've combined both. Well, there's not much evidence for neither of them. And my other question is, you included patients with a BMI of at least 18. You also mentioned that they were very severely ill. How ill is a patient if BMI is at least 18? Because in the Netherlands, we have a healthy weight. It starts with a BMI of 19.
So those are two good questions. The first question is, have we considered separating this out and studying just the diet and just the ketamine? The answer is yes, but we need you and grants and funding and money and a chance for people who are looking at this preliminary data to take it to the next level. So I think that is desperately needed because we need to be able to separate out how much is the therapeutic ketogenic diet contributing and really what does ketamine do, and can ketamine create the kind of synaptic plasticity and cognitive remodeling in anorexics who are not eating fat. Your second question was a good question. How sick is an anorexic with a BMI of 18.2? They are refed. They are refed and usually in our group severely compromised in terms of how much their anorexic thoughts, compulsions, and behaviors take up in terms of their headspace. So all of the women that we had enrolled had been in and out of treatment forever and came in finally at a weight that was stable enough for them to be able to work because they were working mothers with families, many of them. But constantly in and out of their symptomatology. So we on purpose didn't want anyone who was too cachectic because of the EKG issues, the safety issues, and really the risk of weight loss. We weren't sure how it would go in a bigger group when we put them on a therapeutic ketogenic diet.
Do you provide any integration or psychotherapy after the ketamine infusions?
So I met with all of the patients immediately after their infusions. We were interested in data that I haven't presented here, which is looking at the emotional breakthrough inventory, which they were also administered, and looking at whether or not we could correlate breakthroughs to improvement to get a sense of what their experience was like. But we didn't formalize a psychotherapy component. Many of them had therapists that they worked with, although those therapists were not trained in integrating their experience. One of the things that we did do was we offered a weekly Zoom meeting with all of the investigators and all of the patients. They'd all met each other, and a lot of the processing of their experience happened in those weekly Zoom meetings throughout the ketamine portion of the study.
Just an anecdote, really. When we published our little study of ketamine, somebody phoned us up and she said, I was a participant in Ian Mills's study and it changed my life. And she didn't need to phone us up. And I managed to lose the phone number. We subsequently, and so obviously his study was just of ketamine.
Just for one last question before, I think it was probably you who had your hand up first. Yeah.
Thank you for your really interesting presentation and the really bold study design as well. I was just wondering, how do you know if the benefits from the diet are due to ketosis as opposed to a very appealing diet to the average anorexic? As you said, they love this. It's very highly calorie dense, low carb. You could see how, I suppose, there's a big pull for anorexics to take up this diet.
We don't know. We don't, especially with the therapeutic diet, we don't know if it's actually ketosis that is sort of the active sort of magic, or if it's restoring lipids in people who are highly sort of lipid poor, we don't know. We need more work.
Fantastic. Thank you, Laurie.